Our lesson for today is about estimated airway resistance. So airway resistance is defined as airflow obstruction in the airway. In mechanical ventilation, the degree of airway resistance is permanently affected by the length, the size, and the patency of the airway, endotracheal tube, and ventilator circuit. So there are factors affecting airway resistance that we may simplify. So the context of your critical care mechanical ventilation book of David Chang give emphasis to the circumference or the change inside the airway, such as if there is retention of secretion around the lumen of your airway. That is the focus. So when there is secretion formation around the lumen, there is tendency that the circumference of the airway become narrower. So that pertains to the circumference or the diameter of your normal physiology of your airway. Second, changes in the wall of the airway. For example, there will be a cancer case or neoplasm of the bronchial muscle structure. So the elastance or the airway is unable to what they call this, if there is resistance, unable to retract. So there is a possible to increase opposing factor that will create airway resistance, that is increase in laminar flow because of narrow airway structure. And then we have the third, changes outside the airway. Example, outside the airway, it can be external factor like tumor surrounding the airway or your trachea of the that will create restrictive or compressing the airway. So to simplify the topic on airway resistance, so we're focused on the formula of solving the estimated airway resistance. We'll be focusing on the what you call the airflow that is caused by the changes inside the airway or the circumference of your airway. So to continue, so based on the table of David Chang, so it was stated or tabulated in the table 1.1. There are certain clinical conditions that increases the airway resistance. So it can be a cause of clinical conditions such as COPD, or what we call the chronic obstructive pulmonary diseases, that for example emphysema, chronic bronchitis, asthma, and bronchiectasis. Other are mechanical obstruction. So the second one, the type or condition clinical that contribute to increase of airway resistance will be a mechanical obstruction. So what does it mean when you say mechanical obstruction? So post-intubation obstruction. So it can be that the ET tube or the endotracheal tube that is put in the mouth of the patient after post-intubation is kinked, or the patient is biting the artificial tubing or the endotracheal tube. Then the foreign body aspiration, possible that the patient aspire a foreign body. And then the endotracheal tube itself. What is the significant explanation for the endotracheal tube? It can be that the diameter, again, the diameter of the tube or the artificial airway of the patient is very small or not compatible to the required size, no? So later, as we go on with our respiratory physics, we can compute the inner diameter, or what we call the ID of the AT tube that is compatible or required for a certain size for each patient, like for pediatric, adults. So different cases, different computation of the internal diameter that will avoid airway resistance. So right diameter for a right patient. So it can be also a condensation in the ventilator circuit. So our airway resistance refers to those patients that is hooked on a ventilator. So usually the computation later, as we go on with the equation of the estimated airway resistance, is adapted or tailored to patient with endotracheal tube or patient hooked under mechanical ventilators. So the third type will be infection. So if there is an infection or there is a possible infection to your normal physiology, normal anatomy. So for example, clinical conditions that contribute to infection that causes increase in airway resistance will be laryngotracheal bronchitis or Krupp syndrome. We have epiglottitis. So from its words, epiglottitis, it is defined as the inflammation of your epiglottis. So, and then we have the bronchiolitis. So this bronchiolitis, as we review the normal anatomy of your tracheobronchial tree, so there is a pulmonary consolidation. So because of this infection, so ang mga tubes ng airway nyo is obstructed due to infection. So because of this partial obstruction nun siya, or full obstruction of the tracheobronchial tree, these factors can contribute to the narrowing of your tracheobronchial tree or your normal lumen. So instead na normal physiology, the airflow is going to flow to your tracheobronchial tree, to your bronchioles, without infection. So due to these pulmonary consolidations, so the airflow will be affected because of the narrow diameter of your tracheobronchial tree or your pulmonary tract. So if you review your anatomy and physiology, so the branches of your airway from your upper airway down to your terminal airway is getting smaller. So if there is partial obstruction like secretion or other factors, infection, so there will be an increase in airway resistance. So it is also, so airway resistance, let's simplify, it's also redirect to the definition of the patency of your airway. So more patent airway, it means that the airway has no other factor that can contribute to resistance. So later, as we discuss the equation, as we simplify the topic on airway resistance, so how airway resistance can affect the work of breathing. So probably, if you have a narrower airway, so there will be a higher resistance. So we define based on the equation that the airway resistance is calculated by two factors. So we have the pressure and the flow. So if there is a change in pressure, that will be illustrated later. So pressure can be affected by the flow. So as the pressure changes, so remember, we will have two pressure. That's why it was in the equation, there is a delta sign or the triangle sign that represent the change of pressure over the flow. So in clinical setting, relief of airflow obstruction is an effective way to reduce work of breathing. How can we explain this to a very simple explanation? So again, the definition will be relief of airway obstruction is an effective way to reduce the work of breathing. So as you compensate or reduce the airway resistance, so the work of breathing is it's going to be more comfortable to your patients. So less airway resistance, you improve the work of breathing of your patients. So effective ventilation, we may consider that if a respiratory therapist can able to resist or get away higher laminar flow or resistance on the airway, the structure, diba? Including not only the physiology, including not only the tracheobronchial tree, but also the breathing circuit, from the breathing circuit up to artificial tube, the endotracheal tube. If this area or surface are free from restrictions such as secretion, you are promoting a bigger circumference of the airway. So less turbulence flow. So if there will be, if you decrease resistance, the effect of the flow of your air is less turbulence, because if there is a presence of resistance on your airway, since the formula or the equation reflects the airway resistance estimated of patient under artificial tubes. So the formula mismo of this chapter reflects a patient undergoing with artificial airway. So it's like patient breathing on a straw. So as the effect of resistance, you need to, as an RT, you need to eliminate resistance in order to achieve effective ventilation to your patient. So we are going to appreciate equations of airway resistance estimated. So based on your equation, the formula will be airway resistance estimated will be pressure over flow. So flow will be V dot. Be careful. This is not volume, no. So this is V with a dotted sign, which represent the terminology of respiratory medicines. The V dot represent flow, but without that, it is what we call volume. So be careful, no. So if you do reading on your respiratory calculation, the equation is changed, or delta sign P over your flow. This is not volume. This is V dot, which is represented by a flow. So what will be the changes in flow? So there will be two factors that will affect the change in flow in your pressure. So change in pressure will be from your PIP. What is the meaning of your PIP? So this is a literature on your chapter. So PIP stands for peak inspiratory pressure over your plateau pressure. So you should minus, no. So the PIP must be subtracted by your P flat, or your plateau pressure, over your flow or inspiratory flow. So these elements like PIP or peak inspiratory pressure can be found on your ventilator, since again, as I said before, that this equation reflects the airway of an intubated patient. So the change in pressure will be the difference of your peak inspiratory pressure over your plateau pressure over your flow. But be careful, because the answer must be in centimeters of water per liter per seconds. As a default, some equation is in minutes, not in seconds. So the answer of your of your airway resistance must be in form of centimeters of water per liter per second. So how do you convert minutes into seconds? So you divide always by 60. So if the peak flow rate or the PIP is 60, so you will have the denominator of equivalent 60 over 60 of equivalent to 1. So you don't need to compute for 0.3, but automatic if the given in the problem or in your quiz, the inspiratory flow rate is 60. So 60 over 60, that is 1. So you always need to convert always minutes into seconds. So you are guided by your activity, no? So this is only a recap of what you done to your activity. So there is a guide on the equation of your respiratory care based on your respiratory care calculation by David Chang. So everything was explained. It is self-explanatory, but this is only a reinforcement that teaching you to convert first liters per minute into liters per second. So the normal value for airway resistance will be 0.6, or let's say less than 2.4 centimeters per liters per second. So typically we can say that the airway resistance must be less than 2 centimeters of water per liter per second. So those seat works, those laboratory work in the earlier in your canvas I submitted and posted on your canvas will help you more do mental exercises, brain simulation of solving the estimated airway resistance. Again, the ventilation is affected by your airway resistance. So less or contributory factor ang airway resistance. So you need to eliminate as a respiratory therapist airway resistance for to your patient. So again, as we give emphasis that the smaller the circumference of your lumen, the higher is the resistance, or the higher is the fraction that will affect your laminar flow. So it will be so your ventilation will be affected. So in this figure, letter A represent that the diameter of your lumen is bigger. So if the bigger diameter of your lumen, it will diminish, or it will eliminate airway resistance or friction. So your patient has a good ventilation if you eliminate airway resistance. So that is all about for airway resistance. You need to continue read the chapter 2 of your David Chang book in order to appreciate and learn more about the topic airway resistance.